steroids in all the glands, especially the cortex. Of course, this stimulates the production of corticoids. One thing which is worth to circle that ACTH levels are highest in the morning, around 8 a.m. And that's critical because there are a lot of explanation for that. Essentially, Hans Selye's explanation of discover stress said that because when you wake up, this is a stressful reaction, especially if you have to go to work and drive. And the reason that cortisol levels are high because the pituitary produces excessive amount of ACTH, and in the evening it goes down. Thyroid stimulating hormone, of course, stimulates the thyroid gland. As thyroid stimulating comes from the hypothalamus, when it is having the circulation inside the thyroid stimulating hormone. This is thyroid releasing hormone, thyroid stimulating hormone. But essentially, they all end up the stimulation of thyroid hormones, thyroxine and triiodothyronine. Thyroxine has 4 iodines, triiodothyronine have 3 iodines, the molecules in it. So these are the critical hormones, and you will see when tomorrow when talking about the thyroid gland, the most of the thyroid gland produces thyroxine, but in the periphery it transferred into T3, triiodothyronine. And here the lowest is in the evening, is highest during the night. And for the gentlemen who just released, please circle this. ACTH level highest in the morning, that's when we wake up to stress. Lowest here, the thyroid, TSH hormone, lowest in the evening. It's essentially similar to the ACTH high in the morning or in the afternoon. I'm not going to cover this just for sake of completeness. You can read on your own things, the gonadotrophins, which are covered in the male and the female sex organs. The posterior pituitary hormones essentially are two kinds, oxytocin and ADH, antidiuretic hormone. And this also, posterior pituitary also works with the hypothalamus, and it does store, release oxytocin and ADH. Oxytocin controls, of course, uterine contraction during delivery and milk injection, and ADH causes retention of body water, controlling body's electrolyte balance. It's all summarized here. The main issue for regulating all this volume extension is the osmotic pressure, osmotic expansion, and the volume receptor. If you have too much of blood flow, blood is essentially inhibits. If it is reduced, it essentially regulates the posterior pituitary to secrete more or less antidiuretic hormone. The pituitary hyperfunction, so if we finish just a quick review of the hormones, so we are going to the diseases. And this is hyperfunction, meaning increased prolactin. And please remember to circle this because this will be definitely quiz and exam question. What is the most frequent adenoma in the pituitary? And this is prolactinomas, meaning prolactin producing cells. Prolactin producing adenomas. These are involved about 24%. The good news is that most of them are not invasive, so they are not expanding, not metastatizing. These prolactinomas producing galactorrhea, amenorrhea, and unfortunately, especially loss in the males, loss of libido. Fortunately, we have a very good drug for this, not dopamine itself, because the half-life of dopamine, like with noradrenaline and norepinephrine, are very short. But about 40 years ago, it was discovered that synthetic drug, the bromocriptine, is actually a dopamine agonist. So, if your question will be what inhibits prolactin production and counteract the effect of prolactin adenomas, it is bromocriptine. Now, One is another critical information that the size of the pituitary adenomas is absolutely critical. Not only because one is benign, the other could be invasive, but essentially it depends on how they are being treated. This is a brief cross-section of the pituitary adenoma. I believe it was prolactinoma. See, this is anterior pituitary pushing the rest of the cells aside. Fortunately, this is pituitary has a big resilience and essentially can survive a lot of pressure. If you lose about 70–80% of the pituitary, the rest of the glands, the secreted glands will be insufficient. Two important things which you have to know. Microadenomas, which are less than 10 millimeter or less than 1 centimeter, and larger adenomas, which are larger than 10 millimeter or large, 1 centimeter. The importance of this is because microadenomas, and that's again, remember the limit, 10 millimeter or 1 centimeter. These can be controlled by dopamine or bromocriptine. But if somebody has prolactinoma or any other tumors larger than 1 centimeter, any of these, it needs to be irradiated by local radiation or surgically removed. Especially when it comes to large invasive tumors. Again, they don't metastasize, but the benign tumors could be so large that it compresses the optical nerves, like here. Pituitary is here, huge adenoma, this is the brain, the pituitary with a huge adenoma and compressing the optical nerve. And because of that, patients have deficiency in seeing certain parts of their eyes. So this, although the endocrine producing adenomas have a lot of side effects, endocrinologically, but are non-endocrinological side effect also, and that is the neural compression. The take-home message again, remember that 1 centimeter, 10 millimeter, smaller than that, microadenoma, medical treatment, bromocriptine, pharmacologically. Larger than that, other radiation or surgical intervention removal. Hyperfunction of the growth hormone. This is the second most frequent. There are about 14% of all the adenomas. So prolactinoma was 24. So this is the highest. Pituitary growth hormone producing tumors are the second most frequent, 14. And if it is happening during childhood, gigantic growth. But hypersecretion of growth hormone in adulthood causes this acromegaly face, enlargement of the mandible, the bones, so very typical development. But since growth hormone is a very powerful stimulator of all tissues, essentially the metabolic changes are also dramatic, especially since it leads insulin resistance, and that is a type 2 diabetes mellitus. Just early introduction, the type 1 diabetes mellitus is inability to secrete enough insulin, but when you have enough insulin, but then resistance, the receptors are resistant, that is called diabetes type 2, which is part of the growth hormone producing tumors. It also causes hyperlipidemia and hypercalciuria for the loss of the bones. So though calcium is released, bones become weaker, and they are prone to breakage. So here are some illustrations of the hyperfunction, gigantic growth, and if it occurs during adulthood, this is the same person in early childhood. Later on, then this person developed growth hormone producing adenomas, third hyperfunctioning adenomas are the ACTH producing adenomas. So this is 8%. So again, 24% for adenomas, 16 in the growth hormone and ACTH producing adenomas are the others. If it is producing in the pituitary, this is called Cushing disease. The most frequent clinical demonstration signs and symptoms are listed here. I don't want to go over in great detail everywhere, but you can glance at decreased libido, impaired glucose metabolism, muscle weakness, bone weakness, and even acne and hair loss. The deformity is very typical. Most of the fat is deposited in the abdomen. So this is definitely a typical Cushing patient with, again, excessive fat deposition in the face, create the so-called Cushing-Boyd face. After the hyperfunction, here are the hyperfunctions. These are relatively rare in the pituitary gland. One hyperthyroidism is the deficiency of a single pituitary hormones. These are really very rare, and it is not obvious until 75% of pituitary is destroyed, which I mentioned earlier. So we have a lot of reserve cells in the pituitary gland, and you need to destroy about 75 before you get this manifestation. We are not going to drill on this, all these eyes, either invasive tumor is creating this, like I illustrated in one of the previous pages, rapidly growing adenoma of any kind compresses the rest of the pituitary. Iatrogenic by mistake during surgery or radiation therapy, too much radiation destroys the majority of the pituitary. Infarction, the Sheehan syndrome, postpartum syndrome is actually relatively frequent. That's the reason it's highlighted. It can occur after the delivery. I have seen patients dying with Sheehan syndrome after delivery because probably spiking blood pressure makes an infarct, a hemorrhagic infarct in the pituitary. It can occur also in sickle cell anemia. The other eye is injury, infection, immune diseases, inherited, and idiopathic angina. So don't worry about the rest, but do remember Sheehan syndrome and that pituitary is very resilient because if it is less than 70%, you will not notice any deficiency. So let's go to the specific hypofunctions of certain hormones of the posterior pituitary. This is the ADH deficiency, and this is the favorite diabetes insipidus, circulating. We know that there are two kinds of diabetes. The majority is diabetes mellitus, much more dangerous, but there is diabetes insipidus, which is deficiency of ADH. And there is really a lack of motor distraction of the hypothalamic nuclei and tumors, trauma, surgery, or to be iatrogenic. There's also nephrogenic diabetes mellitus, when the kidneys do not respond to ADH. Similar to the diabetes mellitus. Type 1, not enough insulin. Type 2, you have enough insulin, but it does not respond. So nephrogenic diabetes insipidus, you have enough ADH, but the kidney does not respond to this. Due to ADH receptor deficiency. Unfortunately, more and more drugs are causing diabetes insipidus, nephrogenic. Lithium is the most frequent. I have known patients in the VA who were given lithium and died with kidney failure. And that's a bad news because this could have been prevented. How much is the, when is lithium used? What treatment? Which one? Lithium. Anybody heard? Yeah, it's something in the brain for depressive. The depressive is over. So lithium is for manic-depressive, bipolar disorders, and it can be easily monitored if you don't have kidney functions. So So what are the monitors? What these patients should have been doing for monitor? And listed in the VA. So what you measure for hepatic function you measure, but what you measure for this? Which one? Which one? Creatinine. Creatinine, exactly. What is the normal level of creatinine? How much? So that's about 1 to 2. And the other not so specific indicator is what? BUN, which stands for what?
Blood urea nitrogen.
Blood urea nitrogen, which is about 20. Easy to remember. Creatinine, take it as 1, and BUN 20. And the most modern monitor, the ratio BUN and creatinine, which means 20. So remember this, especially if somebody in lithium or any other drug which affects the kidney destruction, including what other drugs, more frequently than lithium. Steroids, exactly. Steroids, any androgens or this? No. Nowadays we see more patients on steroids, glucocorticoids, with renal failure than with GI side effects. Those are the major side effects causing ulcer. So all for steroids, patients on steroids, or any ventilated monitor the kidney functions. Creatinine 1, BUN 20, please. So, summary of the pituitary hyperfunction, pathophysiology. Remember the main functions, including the overproduction and deficiency of hormone. The anterior pituitary hormone, especially the ACTH, growth hormone, and prolactin. TSH is very important. In the posterior pituitary, ADH is the most frequent compromised hormone. Remember the terminology micro and microadenomas. How big is the microadenoma?
Less than 1 centimeter.
Less than 10 millimeter. Micro, less than 10 millimeter, less than 1 centimeter. Larger than that is the microadenoma. Proactinomas, the most frequent, most prevalent pituitary adenomas, and these are treated by dopamine agonists, especially by bromocriptine. Cushing disease, ACTH adenomas, those is Cushing syndrome. If it is the tumor, it's an adenoma in the anteropituitary secreting excess ACTH, that's Cushing disease. If the patient is treated with glucocorticoids or with cortisol for any other reasons like synthetic glucocorticoids for inflammatory joint diseases or for ulcerative colitis, that's Cushing syndrome. And please remember the central versus nephrogenic diabetes simulation. So the take-home message from this is again that in this book you know the pituitary adrenal parathyroid gland as well as endocrine pancreas, and know the names and the main functions of these organs. And please remember the major milestones of discoveries, and please also remember the endocrine versus paracrine, autocrine, and neurocrine secretion. And hypertrophy and hyperplasia are the two different functions. Hypertrophy, enlargement of the glands, hyperplasia,